Let's talk about supereruption of teeth. What is that? Supereruption of teeth occurs when you don't have teeth under an opposing tooth, or if you don't have teeth in an arch, like somebody removes the first molar and they say, oh, I don't think I'll replace that, or the dentist didn't talk to them about it, or they have a first and second molar on the lower arch that are extracted and they don't have any, they have teeth on the upper arch. Teeth move until they hit something. They either grow out of the arch until they hit the opposing arch. They'll grow all the way into the opposing arch, or they move into a space until they contact something. Either the occlusion of the opposing teeth stops them, or they contact the teeth adjacent to the edentulous space. You always want something. Say you took out a lower second molar. It had to be extracted. Well, many times we won't replace those with implants, but if you do have an opposing second molar, you want to be sure the patient has a night guard that extends at least halfway onto that opposing second molar, and they wear it every night. It takes teeth about 48 hours to start supererupting. So as long as they'll wear that night guard every night and it fits over the occlusal surface of that opposing second molar, it's not going to supererupt. But if they have an opposing second one, see, you can see how that one's supererupting into this space. And this tooth, this first molar, is supererupting into this edentulous space. If they'll wear a night guard, then the teeth won't supererupt. Now, I want people to replace these teeth. This person ended up being a full mouth extraction. He had a lot of periodontal disease. You see the abfraction right here. That's from clenching.
Take your practice to the highest level with Dr. Cutbirth's online CE. Click on the link in the description below for dentistrymasterclasses.com. So click below and change your life for the better forever right now.
See, this tooth is supererupted. This tooth is tipped forward. This, when somebody has this, what's that from? Clenching. We used to think that was from toothbrush abrasion. Here's some more. Recession and abfraction is from clenching. See, the teeth have supererupted back here. Here's another case. See, she's got posterior bite collapse. She's missing teeth back here in the posterior. See how the upper teeth have grown down. Their bite from nose to chin has gotten closer together. When you don't have posterior teeth, that occurs. So sometimes people will be missing a posterior tooth and they think, oh, I'm not going to replace it. It's a back tooth. You can't see it. Remember, all the teeth are like horses. The teeth are like horses. You've got race horses and you've got plow horses. If you make the race horses pull the plow, they're not going to be able to do it. They're going to wear out. They're not built for it. Whereas if, you need a big Clydesdale or something like that to pull the plow. That's what the posterior teeth are for. They're the Clydesdales. They pull the plow. So if you're missing back teeth, those should be replaced from first molar forward. If not, the anterior teeth are meant for incising, delicate biting. If they're trying to do the chewing, the grinding, they're not going to hold up. So see, these teeth have grown down. So actually, see, these have grown down almost to the gum where they're missing these teeth down here. So I'm restoring this tooth, this case. You're going to see it in a comprehensive case in dentistrymasterclasses.com in a few months, because we had to place implants, and I'm increasing her vertical dimension. I'm opening the bite. So I've got enough space back here for restorations. Now, how much do you open the bite? Up to about 3 millimeters. No more than 4 in the anterior. I'm not going into that in this case, but I've got cases demonstrating that in the library of dentistrymasterclasses.com. See, somebody, this drives me crazy. Somebody put these implants in up here, but she lost vertical dimension. Where are you going to put the restorations? There's no space. There's an implant and abutment. Somebody put the implants in. This implant's failing, but there's no space. So these are sit down, smoke a cigarette, drink a martini cases. You talk to the patient and you say, this ain't easy. This is a complicated case. And if you go to some young dentist that doesn't have experience, they're going to think, okay, replace some teeth. That's when it begins. We've got decay down here. These cases, these super-erupted cases, these bite collapse cases are really, really complicated. And if you throw in severe wear, they get even more complicated. So look at this case. He's missing the posterior teeth. This guy's an Army vet. See these, when you're missing the opposing teeth, the teeth grow into that space. They'll eventually hit the lower gum, and the alveolar process grows with the teeth. Now, I increase the vertical dimension on a fair number of cases. I'd rather not, because when you increase vertical dimension, you've got to restore at least one arch. If it's the upper arch, you've got to restore them with crowns. The lower arch, you've got to restore them with crowns and veneers, and in this case, you'd have to do implants. So part of what I hope you learn from dentistrymasterclasses.com, we're going to have another seminar here soon just on diagnosis of cases, knowing how to look at a case and understanding how complicated is it. Because if you're looking at a case and you're still wet behind the ears and you've not seen them enough, see this gray hair and this recession? That comes from time on the planet and experience. And I've seen so many of them in 40 years. Hopefully I can help you not make a mistake. We see these teeth have grown down into the socket, so you don't say, down into this edentulous space, so you don't say, okay, let's just put an implant down here. Well, do you have enough vertical bone? If you've lost bone here, is there enough vertical bone between the alveolar crest and the inferior alveolar nerve? What are you going to do about restoration? You got to have enough room for restoration, both the abutment and the crown. What about the occlusal plane? What's their bite going to be like? Are they going to have eccentric movements that aren't going to give them a TMJ or myofascial muscle pain? A lot to think about on these cases. That's why I interview people before we examine them. And about 25% of the people I interview in my private office before they go to the operatory for an exam, about 25% of them I say, you really don't want what I do, because I'm living a very good life. If I do what you're asking me to do, which is patch teeth up, not treat this correctly, you're going to end up with a bad result. And now your problem is my problem, and I don't do that. I'm not going to restore any case that I'm not happy with the final result. And that's what I tell patients. It's really kind of about you, but it's really about me, because I don't want anything walking around out there that's not a result that I'm proud of. These cases, when I see these cases initially, my thought is, I'm not sure I'm going to be doing this case, because they're going to spend money. It's going to be involved. You know, sometimes you think about taking out all the teeth and replacing them with implant-supported removable or removable dentures or all on four, because the teeth are such a train wreck that you can't get it back into a situation that's aesthetic and functional. I tell patients it's like a house damaged in a hurricane. The walls are all soaked, the floors are soaked, they had termites before the hurricane hit, the roof's blown off. There's a point, even if you could possibly save the house, the cost and the amount of work is so extensive, you're better off taking 3 bulldozers at the curb, knocking it down, and starting all over. So some of these train wreck cases, you think, oh my gosh, to get something that's functional, that's not just patched up, that's not going to be breaking down all the time, is just too much. So this case is a very philosophic case. See now, because he's had posterior bite collapse, because he lost the opposing posterior teeth. Look what he's done to his front teeth. This is what really brought him in. These teeth are hypersensitive. See, he's worn that one into the nerve of the tooth, and these are almost there. So use your brain. Think, what is the restoration going to be like? I don't ever do definitive work on any patient except to get them out of emergency until I've done a thorough, comprehensive exam of all the teeth, the occlusion, the periodontal condition, taking diagnostic photographs. I want to know what I'm getting into before I get into it. Does the patient have TMJ or myofascial pain problems? If you do an extensive procedure that takes an hour and a half or 2 or 3, or in my case, every morning I'm seeing somebody for probably 5 hours that's sedated, and you keep their mouth open that long and they've got a myofascial pain or a TMJ problem, you can exacerbate it. And now what's happened? The patient's problem is your problem. So I care for the patient as a patient, but I also care for myself. I don't want to bring problems into my life that aren't my problem. The patient is presenting with the problem. I want to fix the problem. I don't want to make it worse, and then it's my problem. That's the Dental Minute. These techniques work, and they work every time.